Today we have two of Georgetown's heavyweights, and one of the heavyweights, person who makes him such a great person, I'm sure. We're talking about John Marshall and Dan Sulmasy. So Dan, of course, works with us in general internal medicine. We were very fortunate to get him back from Chicago to run the Pellegrino Center for Ethics about 3 years ago. And he does clinical medicine with us as well, but he's a great resource for Georgetown. And both of their CVs are way too long for me to go into, but I'll just give you a thumbnail. So Dan actually trained at Johns Hopkins and was on faculty here at Georgetown back in the 90s, I believe, and then left to do bioethics at various places, including University of Chicago. Came back to us recently, and we look to him for so many things that go over and above medicine. He's also been on President's Council for Bioethics, and just innumerable articles, and just in general, like a real Renaissance man. I thought I knew a lot about literature, but when Dan is in the room, I don't bring it up because he just blows me away. So I'll stick with the young folks who don't know a whole lot about some of these things. So Dan, welcome. And John, of course, is one of the revered doctors at Lombardi Cancer Center. And I say that not just because of the science. He's done wonderful grand rounds and knows oncology just very, very in great detail, but a great role model for the fellows and younger doctors. I have some anecdotal stories, but I won't share them with you today on John. But John, I believe, went to Kentucky Medical School and then was lucky enough, for us at least, to come to Georgetown, where he did his internal medicine oncology fellowship, and then climbed the ladder up to head of medical oncology with specialty in GI. I mean, his patients absolutely love him, and I know I can understand why. And I think that's the real reward in medicine, that we try to foster and teach the young learners that there's more than just the science. It's really how you connect with patients, what an impact you leave on them, and the joy you get in return for doing that. So I'll leave it at that. I think this is going to be another interesting grand rounds, more about personalized medicine. So Dan, are you going to be the moderator, correct?
Yes, so I'll start things off. So thanks for those introductions. We also have the other speaker here, who's actually the star of our show, Liza Marshall, John's wife, who is going to help us, I think, learn more about the personal experience of cancer in ways that I hope will be helpful and illuminating for all of us. So the title we have is When the Ethics of Cancer Care Becomes Personal, an interview with Dr. John Marshall and with Liza Marshall. And not only is our topic a bit different, but our format is going to be different. And I'm sort of likening what we're going to do to another televised event that occurred rather in the not too distant past. This is me, sort of. That's the role I'll have, is of Oprah. I don't quite look like Oprah, but that's the role I have. And for John and Liza, they are our royalty for the day. They, I think, actually look better than the royals, and perhaps I think are going to be a bit more honest in what they share with us today. And that's really for me going to be the end of the slides. well, I've got a few more to just tell you that really what we're going to talk about is their book, which is going to be forthcoming from Idea Press. It's called Off Our Chests. It'll be available on May 4th, 2021 on Amazon. If you want to get it other places, those are the ISBN numbers. It has already received pretty good advanced publicity. Here's the dust cover reviews from people like Katie Couric, Siddhartha Mukherjee, the Pulitzer Prize winner for The Emperor of All Maladies, and Daniel von Hoff, an oncologist. So other people have read it. I've read it. And this is going to be like an Oprah book review. And now I'll stop my sharing, and we're just going to really chat about their book and the experience in a way that I hope is going to be illuminating for all of us. So my first question, which could be to, and I should also say that while I told them some of the questions that I might ask ahead of time, there are a few ringers I've got in here, so this is going to be spontaneous as well. But my first question that I'll put to both of you is, why should anybody read another book about cancer, about breast cancer, particularly another personal memoir?
Was that a point to me? Are you raising your hand to answer? John and I have not done one of these in separate rooms on separate computers, so we'll have to see how we manage that. Yeah, well, I had the same question, I have to say. As we started thinking about this, and I do feel in many ways my breast cancer experience was sort of every woman's breast cancer experience in many ways. They're all different, but in many ways they are the same. One thing that set this book or this story apart, I think, was that many of you probably know, John has been a long time railer against what he refers to as the breast cancer machine, in his his efforts to really get the attention and funding towards GI cancers. It's, the disparities between breast cancer funding and advocacy are just really, and all the other cancers are really, really stark. And so I think John viewed my getting in breast cancer as a form of global vengeance. So he figured there was some dramatic tension there, which might make for a more interesting story. And then John's background as an oncologist obviously brings a completely different, or not completely different, but a very different aspect to this story, and allowed him, I think, really to raise, both of us maybe really to raise the sort of curtain, to look behind the curtain of what cancer care in America really looks like.
I mean, we didn't really want it to end up being a breast cancer book. Some of our people who were helping us thought that was the most appropriate emphasis because of its popularity and recognition out there. But we did want it to be about other cancers. So and what that experience is like for others in sort of comparison to breast cancer. But also the experience we had was in some ways unique, in many ways unique, because we were so spoiled by many of the people on this Zoom this morning, and who took care of us in a way that was really remarkable. And I think most patients don't enjoy that kind of experience. And so we wanted to share what that was like and how that might influence others going through the journey. But equally important, could we create some content? Could we create a book that this crowd would like to read? Not just patients, going through the experience, but that would be meaningful for the medical community as well. So we hope in the end that does have some positive influence for all the various audiences out there.
Yeah, I'll probably circle back in a few minutes to the sort of outsized emphasis on breast cancer, both in public consciousness and funding. But maybe we could start a little bit more about the experience, which I think, as you said, is generic to cancer patients. And start with this, John. We talk a lot and teach a lot about giving bad news. Maybe you could tell us a little bit about the way in which Liza learned about her cancer and how you were involved in that.
This could also be our safety story for our meeting because it involves, in essence, a HIPAA violation. So Liza had some problems with her breasts over the years and had biopsies. And in the past, I guess the one had been negative. And so we were going through another one where we were very anxious about what was going to go on, but weren't really prepared for a diagnosis of breast cancer. We just thought it might be another benign biopsy. And I was at this desk and down the hall there going through my morning mail back when we used to have mail instead of email. And in the stack was a breast cancer pathology report. And I looked to the top and I saw my wife's name. And it was at a time when, you know, every morning we would kind of check in with each other on the phone on what was going to happen that day, even though we'd just seen each other 15 minutes before. And I said, Liza, you have breast cancer. I didn't know what else to do. It was one of those where I couldn't not tell her, but I wasn't prepared to tell her either. So, you know, we do a lot of bad news in our line of work, and we're pretty good at it. And we learn how to do it and do it well. But I didn't do it very well that morning. I didn't, it was just because it totally shocked me. So fortunately, those of you who remember Minetta Lou, she happened to have also gotten that report that morning because Liza had been enrolled on a study and Minetta was the PI of that study. And so she appeared in the office while I'm on the phone with Liza telling her this, and thank goodness took the phone from me and took it from there.
Liza, what did it feel like to learn about your diagnosis that way from your husband?
Well, at the risk of being repetitive, I mean, I really thought he was joking. And many of you who know John, he tends to make jokes that some people might find a little jarring. And so he said this, and I had no reason to think he could see my pathology report or wasn't even really expecting anything back. So, but once I realized he really wasn't joking, you know, I was floored and, you know, immediately deer in the headlights, stunned. I mean, John doesn't give himself enough credit. Minetta did come in and Minetta did take over, but John had already started the process of, this is what we're going to do. You will come down here today to get a scan, an MRI. And he immediately switched, I think, really admirably to oncologist mode. And for me, I didn't have any idea what to do. This was a completely new world, but to have both John and then Minetta just tell me what to do. I mean, I talk about this a lot in the book, but there's so much, I think, particularly in cancer, because there's just so much information and so much science and so few answers really, that I think that for a patient, being told what to do is, for many of us, really what we're asking for. It may not be the right thing to do, but it's really what many of us would like. So having that control suddenly inserted and I just had to start following instructions really helped a lot.
Well, but I had nothing else to do. I knew nothing else to do but go into oncologist mode, right? You know, that's what I was most comfortable with, and I knew that it needed doing because I didn't understand the caregiver role or what I was supposed to feel, and the impact of that wham diagnosis really changed me forever too, because you don't really understand sometimes what we say to people and the impact that it has for everybody downstream.
Yeah. Had you ever told anybody they had cancer by phone before?
Yeah, never. Well, you know, a lot of people have recurrences and things like that. So, you know, and a lot of times we know patients well enough to where that's how we deliver the news. In fact, with a lot of our patients, if you say, we need to see you in the office, you know, it'll make their blood pressure go up even higher. So it's one of those that you almost have to say, this is what's going on, but you have to also, of course, be prepared. I mean, this is the lesson for all of us, is you know you're about to change somebody's life. You have to be prepared to sit down and be calm and listen and talk and know that that person is not going to really hear much of what you say after that opening sentence. And so you have to manage that. You have to go in with the management plan, knowing that you're about to rock somebody's day.
And Liza, most of my colleagues at the Kennedy Institute in the philosophy department talk an awful lot about patient autonomy. It sounds like you didn't want to be autonomous.
Yeah, I mean, I think that's true. It's one of the things I've thought a lot about, particularly as we were writing this, I think. And I mean, I think it's really a difficult line to walk. And as I say, I mean, not that I know that much about other diseases, but I think particularly in cancer, the variety of clinical trials they are, and the honestly different things that they all do, and the different drugs and the different side effects, it just seemed less of a straightforward path to me. And I was left autonomous. I mean, I was asked to make these decisions, even as I sort of said, what do you think I should do? To Dr. Liu, she was always very careful to make sure that that the decisions were mine. And in the end, I don't know that I made the right decisions. I mean, and some of this is luck. I mean, we joke even now. I mean, who knows? It may have been the surgery that cured me of the cancer. Maybe I didn't need to go on any of these clinical trials. But nobody else can know that answer either. I mean, we're all just a little bit shooting in the dark. And so, as I say, I don't know that there's an answer to that. I mean, certainly patients should be able to make their own decisions. But I think I think it's not so much about telling them what to do as it is about translating what those options are, because anybody's, I mean, the packet of paper that's given to a patient to read about a clinical trial is 30 pages long with many words I didn't understand. And I understand, I mean, John said to me the other day, he goes, "Oh, you're ready to be an oncologist," as I was trying to type translate or something for somebody else. And but my knowledge is still very basic, so I can't imagine for somebody who hasn't had exposure to names, what the generic name of Taxol is, that kind of thing, could approach this in any sort of educated way without guidance in translation.
Yeah.
I personally don't think, Dan, I'm sorry I just don't think what I've come to realize is we could never educate a patient enough to leave them equipped to be autonomous. We could never do it. No matter how we educate, no matter how we talk to them about choices, no matter how long we spend in there with them, they're never going to have the knowledge or instincts that we bring into the room. And so I think handing off autonomy is a bit of a cop-out from the medical community as well. That on some level, we are personally responsible for advising that person. When they ask us, what would you do? We can't dodge that. We, on some level, have to do our best to interpret the situation for them and give them as much information as you can so that they can decide, but you get a vote too.
Yeah, no, I think that's probably right. I know one ethicist colleague of mine who had breast cancer, and said that she felt when the decision came up about whether to do a prophylactic mastectomy, said, well, you could decide one way or the other. It's up to you, and that's all. And she said she felt abandoned to her autonomy without any kind of guidance, any kind of at least suggestion of what might be the right thing to do.
And I think stealing a playbook from your world of saying, here's the benefit, here's the risk, and everybody weighs that a little differently, and then to say both are okay, but you need to put your own little pieces of weights on there on whichever side you're going with. And I think that's the best we can do.
Yeah. Yeah, it's not simple, certainly. Liza, when did you hear triple negative? Did you hear it the first day, and how did you react to that? Did you start Googling? Did you just ask John as being better than Google, or?
Yeah. I should go back and read the book. I can't remember now when I first did hear it. I think, I guess the pathology came back, John, about a week or so later. I mean, yeah, it was on the first round of pathology, I guess, after the biopsy. So within the next couple of days. Well, no, I guess it was on the thing you got. I guess it was actually on that. So I guess it was the first day, basically. I didn't know what it was. I did meet with Minetta pretty quickly thereafter. I mean, within the next 24 hours, I think. And she told me very, very basically what it was. I mean, just that I didn't have any, hormone receptors, and it wasn't HER2 positive. But again, those were, even though, again, I had been around people with breast cancer, I didn't really know what those things meant. And nobody ever really talked about prognosis. I mean, I got all that information from Google, which, was probably not a good idea, but I don't, you can't, I don't know how you not know that. I mean, how you, and I understand why nobody wanted, what was the point in a doctor telling me that? I mean, at that point, we weren't going to do anything different. Whatever my prognosis was, we were going to, do the same treatment. But, I probably would have gone to the library if I hadn't had Google. I mean, you've got to know what this is. So, I mean, there was a hint. I think there was a suggestion that this wasn't great, but there wasn't. The statistics I didn't really see, or didn't internalize until I really saw them in print.
Yeah, that's interesting, isn't it? That even for the audience, that even the wife of an oncologist turns to Google to get information about this. That tells us something, I think. Switching a little bit, John, you were cast not only in the role of being the first person to disclose the diagnosis, but then immediately, and this is something for all of us as the caregiver for your spouse. So tell us a little bit about your experiences as a physician caring for a family member, a spouse who's got a malignancy.
Yeah, this is one of those cases where I kind of knew too much, and I had to partition off a lot of emotions, quite honestly. Liza basically had nearly inflammatory triple negative breast cancer. And, I could take, doing what I do and all the sick people that we take care of, it was very hard for me not to go down that path with Liza. Chest wall involvement, all sorts of terrible things. And the thought of being a caregiver in that space, watching the number of spouses and family members that I have watched over the years be incredible caregivers, the amount of time they partition off, they quit work, or they change their jobs, or they totally rearrange their lives in a way so to support their family member. And so part of me was like, well, come on, I'm in the peak of my career's going through the roof, and I'm busy, and I've got my own patients to take care of. We've got young kids to take care of. That's too much. I'm never going to be able to do all of that. And I'm not sure that no one really does, I'm sure, but Liza was nice enough to get her care here, which allowed me to balance a lot of that. It's funny, I would be in my clinic in hallway 2 and down in Lombardi, and then Liza would be in exam room down one corridor, and I would come out of my clinic, go down and sit down and be a caregiver, and then get back up and go to my clinic. So she made it very easy for me to be supportive there. But one thing I didn't do, I didn't really feel like I should, and this is a little weird, of course, is that I didn't really ever look into her cancer. I never snuck into her chart. I was invited to grand rounds. I didn't go. I didn't want to go there. I did after that one pathology report. I didn't ever look in her, look at records and stuff, and really tried to be her support and rely on the team, the breast cancer team, to coach us on that. I wanted to have a voice, but not a dominant voice in that. I wanted to have the caregiver voice in that. So I had to sort of divide those things. Liza tells a funny story about it's Shauna Willie, Minetta Lou, and me as the husband, and Liza in an exam room down in Oarsman.
Like Claudine instead of Minetta.
And Claudine, yeah, Dr. Isaacs was there instead of Minetta, right? And we're all standing, and Liza's on the crinkly paper, right, on the table, and we get into this rapid fire discussion up here of strategy, and I look over and I just see Liza's face like, I have no idea what these people are talking about, and and eventually we had to bring it back down. But that, you know, that was a moment when I left my role and joined the multidisciplinary team in some way, and I realized that was not the right thing to have done at that moment. So my job was to translate that so she could get something out of that discussion. And so, but anyway, we patched it together. We relied on lots of friends and family, many of the Georgetown team, and took incredible care of us, but also church friends and neighborhood friends and others that it required. And yeah, I was part of that village, but we could never have done it without all of those people that were involved.
And you mentioned knowing too much, but there's also an interesting anecdote in the book about knowing too little, particularly about technical things like injections. You want to say something about that? Yeah. Yeah.
No, because I'm totally embarrassed. I can't believe I left that in the book. But but this is a great lesson for all of us. We were sent home with a prescription for some Neupogen, and the nurses offered, I think, to teach me, and they said, "Oh, but you probably know how to do it." And I was arrogant. I said, "Sure, I know how to give a shot." And so we went home and we filled the prescription and all of that, and we were in our bathroom, where all medical procedures at our house happen. And we made the kids go outside, but they were listening in at the door. It's kind of funny. And I gave Liza the shot. She screamed bloody murder, just screamed like I had killed her. And the kids come charging in and like, "Dad, you've killed Mom. And how could I have done this?" And I got the nastiest look. Those of you who have spouses that can give good looks, I got one for that. I deserved it too. But anyway, so the next morning I kind of head tucked going up to 5 North. And if those of you who know Mercedes Watson, she's an incredible nurse up there, runs that unit up there, looked at me and said, "Dr. Marshall, you didn't know how to give that shot, did you?" And I'm like, "No, I did not. I didn't warm it up. I didn't give it slowly. I didn't read the instructions. I didn't look it up on Google. I just gave it." And so every time I send somebody home with a prescription for, I don't know, Lovenox, I am now very sensitive to that moment, and say, you know, no longer, "You'll figure it out. Let's train you. And I've had physicians that I've done this with. Let's make sure you know how. I want you to give it in front of one of our nurses," that sort of thing. So I have an added respect for what we ask our patients to do when we send them home with all of this self-administered stuff. And that was just a simple Neupogen shot.
Liza, maybe you could tell us a little bit more, which might be very helpful for the audience, about just your own coping strategies. John said a little bit about it, but maybe more detail. What got you through diagnosis, therapy, et cetera?
Yeah. So for, you know, and everybody's different. So, for me, really, honestly, I think keeping going with my life the way it was as much as possible was really important to my mental health. So, you know, I was involved in our kids were 10 and 13. I was very involved with their school. I was actually already involved with the cancer organization separately from this. And so as much as I could, I just didn't drop anything. And I kept, kept all my appointments. I kept my committee commitments. And, you know, if I needed, the rest, obviously the day I was in treatment. And fortunately, my bad day was usually Sunday when most things are quiet. So I really pretty much kept everything up. I will say that, I mean, in the first place, Lombardi is wonderful. I will, a plug for the arts program. It was such a joy in my life. I honestly referred to coming for chemo as chemo camp, because, we had dancers who came in and people who came in and wrote poetry, and we did art, and it was like camp. And not only that, of course, everybody was lovely and warm, but the arts program is I really do think it made a difference to my mental health and getting through the day, the long day there, and to lots of other people as well. And then, I think support in whatever form one can find it. I said I've been very involved with an organization called Hope Connections for Cancer Support for many years, which provides support groups for free and education programs and mind-body programs. But I also, I fortunately had my own group of friends, my parents who, while they could never talk to me about it, and I'm not sure my parents ever said the word cancer to me or even really acknowledged what was going on. But at the same time, well, they did acknowledge, they didn't acknowledge it in words, but, tremendously helpful, taking care of our kids, taking care of the dog, doing whatever we needed during that period. So we talk about this in the book about cancer being a team sport, which actually applies to a lot of different areas. But I really think the team that one can build around oneself, whether that's institutions or whether that's individual people, has, at least for me, made such a difference in being able to get through, some of it being the fear and the anxiety, and some of it just being the physical manifestations of what chemotherapy does to you and surgery.
Both of you talked at different points in the book about your faith being a source of support. Can you tell us a little bit more about that? Was it social support through members of the church? Was it prayer, meditation? What aspects of your faith do you think really helped you in coping?
I'll start. We both were raised in the church, and it has been an important part of our lives. We've raised our family in the church, and we work on our faith all the time. Faith is, for I think both of us, not something that's just a done deal. It needs constant management, constant study, and reflection. And I personally have had, very clear moments of God's presence. And in fact, my faith has been an important part of my own personal coping with the loss of patients, with the challenge of our work, with so many patients that die on my watch because of the nature of my practice. And, having to balance the pain of that with what I believe is an afterlife. I joke, some of the residents or fellows may have heard me use this line. I use it with some regularity. I'll be counseling an end-of-life patient. And I will joke that, I used to teach Sunday school, and we would teach kids how great heaven was. And then the rest of my week, I try to keep people from going there. So actually, that almost always gets a smile out of a near end-of-life patient. And sometimes I'll even go to the next line and say, if next time you see that light, why don't you go to it? And talk about that interface between this world and the next. And different people have different feelings about the next life, so you have to be careful as a clinician. But for me, every lost patient, the way I dealt with that, honestly, was I would say it out loud, that there's another angel behind me, pushing and inspiring and saying, don't stop, keep working on finding cures, finding better treatments for the next patient. So I use my faith as inspiration to keep going. But there's no question when bad things happen, you question your faith. But for us, for me at least, it added to my experience with God, quite honestly. It gave me more time to reflect on the difficulties of life and coping, both personally and professionally. And so it ended up becoming richer after the experience.
Liza, did anybody in the team ask you at all about your own coping and whether religion was part of that or not? Because there are surveys certainly that say that patients, by and large, are interested in asking those questions. Even one of the ones that I did in Greenwich Village, not exactly an overly church-going area of the United States, and many people who were considered themselves spiritual but not religious wanted the doctors to ask about their own spirituality. And it was in an outpatient cancer center at St. Vincent's Hospital. Less than 1% had actually ever had a doctor ask them about their own spirituality and coping. I was wondering if you had that same experience or something different.
Well, this is one of those places I think where my experience is probably different from the average patient's, because I knew, obviously I had several doctors, but Dr. Lou's the one obviously I spent the most time with, since I was she was handling my chemotherapy and seeing me on a bi-weekly basis. And so we already knew each other a little bit, so I think she knew. We chatted every time we saw each other, and we actually chatted about her religious background and my religious background and things like that, but not so much as her asking me as part of my care necessarily. It was more of a not exactly osmosis, but it came out through our just general discussion. So I think she had a pretty good sense of what my beliefs were, not specifically, but just that that I had faith and belief in God, and I was fairly I had some equanimity about the thought of death too, and I think sort of to the point John makes, that because I do believe there is something after. I'm not. There were lots of reasons I didn't want to die, and obviously I was willing to put everything I had into staying alive, but I also wasn't filled with deep fear about that, I think, which in the end probably for me at least helped get I think get all of us through what we needed to get through.
Mm-hmm. John, you interesting, maybe it was your own faith that inspired this, and I'm not sure it's necessarily the best, but you made a vow you were going to treat all of your patients as if they were your spouse. And tell us about trying to put that into action and what happened.
Well, I felt guilty, quite honestly, for what the care we got. In my role as clinical director of the cancer center, what I'm supposed to be in charge of is the overall product, what everybody walks in here to receive. And what we received, the timing, we never had to call radiology. That just magically happened. So there were all sorts of things that happened for us that we rely, and we were capable of doing it, right? So we could have done it, but they just did it for us. And I wanted to try to share that same level of service for other patients. And I actually started out that way. I mean, that's a lot of how I used my energy after Liza's diagnosis to reshape the structure of our division, the flow of the cancer center, new FTEs. I won some new FTEs from the front office for what we call nurse navigators, and to try and provide the same, anything closer to the same level of care and service that we had. And I think that the punchline of that was I couldn't. Whether it was on a personal level for my patients or on a systemic level for the department, for the division, I would always fall short one way or the other. And so with my own patients, and this is, I think, what really cost me in the end, is with my own patients, that familiarity, the friendliness, the warmth, it sort of took down my objectivity wall. And so people were, I gave my email and my cell phone and would try to be responsive, because I knew, on the other hand, what it felt like to be waiting on a CT scan result, what it felt like to be waiting on a blood test. And so I wanted to be as responsive as I could be so that they didn't have to, be anxious about that is, I shortened that anxiety as quickly, cut it out as soon as I could. And so in doing that, though, I lost my objectivity. And so it was when patients would die, when patients were getting sick, and when I couldn't do much more for them, that hurt. It hurt more than it used to. I felt it more. Every new patient, it sort of evolved to every new patient that had, say, metastatic colon cancer. While I was, here we go, we're going to fight at the beginning, there was a part of me that couldn't get the voice out of my head that says, I'm going to watch that person die. And I'm going to try to do it a while from now, but I am going to be there when that person dies. And they don't know that. They don't, right? I can see it. So that began to cause me some strain, quite honestly. I don't think I became impaired at all in terms of my ability to practice medicine, but it cost me. To the point of, as you know, what I think it was on the way to burnout, real burnout from that. So both trying to manage that for the division and manage that individually got me to a place where I was tired.
How did you know you were burned out? What did you actually feel?
He was very cranky.
Yeah, go ahead. Let's ask the boss. Yeah.
Yeah.
Yeah, I mean, he did. He really, I say that somebody, I think John came home from work one day and said, somebody says I've lost my sparkle. And, he really had. He had lost his sense of humor. He had lost his sense of patience. Not CE, with a lot of things. I mean, he just was clearly much more on edge. Much less able to relax. He wasn't sleeping. I mean, that was a pretty big one, which obviously contributed to all of those characteristics or quirks or whatever. But John, I didn't mean to.
Oh, you're the better observer. I mean, I think that's true. Yeah.
And how did you handle that?
Yeah.
Well, I still didn't start drinking till after 6. Let's put it that way. But,
that's good. That's good.
Yeah, no, that's good. Even though there's a lot of booze right over my desk, that never opened, I promise. No, it was. I actually tried new things. I honestly reworked. I sort of tried to reinvent myself. I tried new projects that would re-inspire or distract. And the university and the hospital were incredibly supportive of that. I reduced some of my burdens from the cancer center job and reshifted to new projects that I thought would kind of turn me on and excite me. And they did. And they were really cool things that I was able to do, lucky enough to do. But in the end, it became obvious that I needed a reboot on some level.
Well, and I think it stopped you. I mean, with the sabbatical, you sort of made a shift in how available you are to your patients, which has been I think has been hard, but at the same time, absolutely necessary.
But I think part of the lesson, again, for the audience is that it seems like you were willing to go and talk to other people and let them know you were hurting, and they were supportive, right? And helped you, right? So
yeah, I was very transparent. I mean, to my primary care doctor, to my colleagues here, to my wife, to our church, it wasn't that I hid this away and I knew I needed something. I needed something different. Life wasn't right, and so I shared it with colleagues out and around the country, and I shared it with people here, and because I honestly wanted somebody to come in and say, I got just the idea for you, right? And I was floating the idea. As you can tell, we are not very private people. So we kind of share our feelings on our sleeves, I think in some level to hope others will share back with us. It's our way of communing. Well,
I think importantly to mention, I was hesitant to say this, but I think it's in the book. I know it's in the book. So, but you did go see a therapist for a little while too. I mean, we all have. So, I think it is. That's one of the areas that I think doctors in particular are very hesitant to talk about it, to admit that they needed, some professional help. And I won't push you into that.
No, it's fine because the therapist clearly told me where my emotional maturity was, because she gave me a book that was written for like 7-year-olds on my feelings. And so it literally is a picture book that she says, I want you to take this home and I want you to read it and kind of figure out which pages are it was a big picture book. I mean, give me a break. So anyway, I realized my emotional maturity needed a little development.
Yeah, well, that's good, and that's a valuable lesson. Liza, another thing that can sometimes happen for people like you who survive is dealing with being a survivor. What's that like for you? I mean, surviving triple negative breast cancer is pretty rare. Do you have like survivor's guilt? Are you still fearful that it's going to come back, or you'll get a secondary malignancy? What are things like?
In reverse order, because the bigger question is probably the first one, but I do worry about secondary malignancies. I don't worry that it's going to come back. I mean, I think I'm past the point at which, at this point, anything essentially would be a new cancer. I mean, even if it was related to that, it's been long, just in time. 15 years to me seems like it's a new road at this point. But as I've said, we can all be hit by a bus tomorrow. So and never mind having just lived through a year in which people were fine one day and dead of COVID 2 weeks later. So I think at least for me, as much as taking the fact that I have survived and using it to appreciate what I have and that every day is honestly a gift. But then also, I hope, again, this past year, particularly with the, all the protests after George Floyd and all that's come out about racism, I hope will not come out, but maybe that many of us have finally opened our eyes to. I hope that we're all on this planet for a reason, and that we can use, the gifts we have to make life better for other people. And as John says, we were very, very blessed in the care we have and had, and the access to insurance and the knowledge we had. And so maybe that's survivor guilt, but if it is survivor guilt, I hope there's some good that comes out of that, I guess.
And John, before we open up to further questions, do you think breast cancer still gets too much money, and have you changed your mind on that? Too much attention?
It's a relativity issue. So I don't mind that they get that much money, but just so we set the stage properly, at not just a few years ago, it's gotten to the balance is a little more even now, but there was 10 times more funding for breast cancer than all the other cancers combined. And breast cancer enjoys a 90%, all comers, 90% 5-year survival. So, in my world where we don't get much research, there isn't much basic science going on because of it, we're not too much better than we were 10 years ago. We're a little better, but not too much. So to me, it's a balance thing. And so I'm not different in my feelings. I'm grateful to the success. Liza being here, in my opinion, is a demonstration of that success. But why should one disease have all of that success and the rest languish behind? And there's good reasons there are good political reasons for why breast cancer became one of the strengths. And for the older members of our gang, we know that this center, Lombardi, was really one of the leaders in breast cancer research for all of that. So that kind of rubbed it in my face a little bit more. But so I'm very grateful, but it's a demonstration of what that kind of investment can do. And I think it'd be cost effective. So every time they cut the NIH budget, or Katie Couric, 2 weeks on Jeopardy, right? Here's a famous person raising money on a major national television show, and in the end, I think she got $250,000 or something like that for 2 weeks. That is 5 patients on a clinical trial, right? So that's nothing. That is nothing after that. Where so we still need we have miles to go. So we need to rebalance.
Liza, my feminist philosophy colleagues have suggested that part of the reason there's such an emphasis on breast cancer is that the breast is really just an object of male gaze, and that that's the dominant way that the money. That's the only reason the money goes there. Even BRCA 1 and 2 are called breast cancer genes in a strange way. Do you buy that, or should I tell them they're all wet about that? That it is not merely another example of male dominance in society.
Well, I guess I would say that I think the attention on it is an example of male dominance, but not for that reason. That may very well be true. It wouldn't. I mean, I'm sure that plays into. Plays into a lot of decisions. My take has always really been, I think, that when you read about the history of breast cancer and how it was treated and how barbarically it was treated in comparison to, I think, many diseases that happen to men, much more about worrying about preserving men's sexuality and bodies and all of that than there was about women's. And so, as with many things, I mean, again, the last year, when some, people eventually get angry enough that they react and they organize. And so, whether it's Susan G. Komen or whoever else that sort of, took the charge, I mean, not the Susan G. Komen organization, took the charge in the lead in that charge. I think much of it is a response to how badly women's health issues were being treated up to a certain point, and the point at which women finally decided that it was time for them to take the reins and really go out and raise the money and lead the funding, and I mean, not the funding, but the research and lead advocacy. So it's a feminist answer, I suppose, but maybe in a slightly different way.
Great. I want to save a little time for questions from the audience. Robin or Dennis, do we have any that you'd like to pose?
We have one from Dr. Gandhi. Thank you, Liza, for sharing your story. And I would like to thank all of you for an amazing talk. It was quite humbling for most of us to know what that is, the experience is like. Another thing to think about is the way that even physicians feel as patients, and wanting to know and wanting to be told. So thank you for sharing that, both of you.